Good afternoon. Thanks so much for joining us today. My name is Ben Miller. I'm the Chief Strategy Officer for Wellbeing Trust, and you have found yourself in the third of our Healing the Nation webinars. We appreciate you joining us live, and for those of you that will watch this when it's not live, thanks for joining us then as well. Today's a good one. We're going to talk a lot about data and some numbers, and we're going to do it in a way that we think is going to really grab you by your lapels and make you pay attention to some of the things that our nation is facing. Alicia, let's go to the next slide. We've got an all-star group of folks, as you can see here on your slides. We're going to kick off today with me just saying a few words for context. Then we're going to turn it over to Dr. Nadine Gracia, who is going to describe a little bit about the work that she and Trust for America's Health has done. Then we're going to move to our Kaiser Family Foundation friends, Cynthia Cox and Rachel Garfield. Excuse me, we're not going to them next. That's just the way it is on the slide. We're going to Dr. Jack Westfall next, who is going to talk a little bit about some of the predictions and projections that have been made on deaths of despair and how COVID really could exacerbate some of those deaths of despair that Dr. Garcia will be talking about. And then we're going to finish, last but definitely not least, with our friends at Kaiser Family Foundation, Cynthia Cox and Rachel Garfield, who are going to talk a little bit about some of the data that KFF has collected and what we as a nation might be able to do together. So next slide, please. Interestingly, right now, it doesn't feel like an understatement to say that our country is doing some pretty deep soul searching. We're having a lot of hard discussions right now as a nation, and I think we'd be remiss not to at least acknowledge that in the context of this webinar. We're talking about things that are long overdue, issues of race, issues of poverty, undergirding these ongoing problems of health disparities that we've surfaced on this webinar and these series of webinars. Systemic inequalities and a flawed and fractured system and structure that has paid little to no attention of applying equity really are legacies that we've all inherited and things that we all want to address in our own way today. But today does feel different. Could it be the day that sees change? It feels like it. I have hope and I have optimism, and I'm sure many of you do too. So while we protest, while we continue to fight for systemic and cultural change against things like racism, and we see the pain, we see decades of suffering, and we see hope. Our nation's mental health is at risk right now, and as you will hear today through data, we do have some problems. Today's webinar is about data, specifically what the numbers show us about COVID and our nation's mental health. It feels timely and both critical to get this right. Next slide, please. As we've been talking about on these webinar series, that our nation has not necessarily nailed it when it comes to mental health. We've had a lot of problems of being fragmented and fractured over the last decades, and calls to action have been somewhat heeded, but mostly ignored. Healing the nation requires us to come together in a comprehensive way to really put the needs of our communities front and center, to develop policy that's built on the evidence, and to really stop paying attention to just those almost beliefs that we have of what we think is going to work, but actually fall back into the evidence and listen to the solutions that we know are going to work and have been proven to work. Next slide, please. As many of you know, and I will remind us until things change, Congress has yet invested very little in mental health in response to COVID, $425 million to be exact. While more money could go to help, we have got to re-examine the structures in which that money goes. As I said, things weren't going so well before COVID, so let's use this time to really reimagine and examine new structures, new systems that might be more effective for people. Next slide, please. So that's why we do these webinars. And that's why we created a framework within Healing the Nation. Wellbeing Trust was committed to coming up with a vision in partnership with many of you for what excellence could look like in our nation. You can visit the website at healingthenation.wellbeingtrust.org, and you can get a sense of both the federal policies that we've been talking about since we launched the report, as well as the framework that we're using to drive people towards action. So without further ado, let's get started. Dr. Garcia, I will turn it over to you.
Thank you, Ben, and good afternoon or good morning, everyone, depending on where you are in the country. It is really a pleasure to be with all of you. Again, my name is Nadine Gracia, and I serve as the Executive Vice President and Chief Operating Officer at Trust for America's Health. And it's such a pleasure to be a part of such an important conversation, and especially with our wonderful partners at Wellbeing Trust. Ben couldn't have said it any better with regards to where we are as a nation, certainly as we are grappling with the COVID-19 pandemic, which has exposed certainly the systemic and structural inequities that have long existed in our country. And then now, more recently, the incidents of racial violence, which again have existed and been longstanding in our country, but really serving potentially as a pivotal and turning point for our country to truly reach its potential of advancing health equity for all. Next slide, please. I'd like to start by sharing a little bit about our organization. Trust for America's Health, also known as TIFA, is a nonprofit, nonpartisan public health policy, research, and advocacy organization. We're headquartered in Washington, D.C., and we promote optimal health for every person and community as a national priority. And we envision a nation where prevention and health equity are foundational to policymaking at all levels of government, all levels of society. What we do is develop reports and other resources and lead initiatives to really provide evidence-based policy recommendations that will advance a 21st century public health system that is ready to meet the growing demands and needs of the public health of our nation. Next slide. We have many policy priorities at Trust for America's Health, including areas such as public health emergency preparedness and public health funding. And today's discussion is also inclusive of one of our policy priorities, which is the topic of mental health and specifically substance misuse and suicide prevention. We, along with our partners, Wellbeing Trust, have published the Pain in the Nation series. We've been partners over the last 3 years in which we've issued a series of reports that really highlight the mortality from what we see as these epidemics of suicide, drug deaths, and alcohol deaths. And we've also issued reports that focus specifically on certain populations, as well as certain systems and how they can work to address and reduce these mortalities. Next slide, please. Our latest report was actually just released last month in May 2020, which is our Pain in the Nation update report. And what this report shows is the most recent data from 2018 with regards to mortality from drug, alcohol, and suicide deaths. Really, the top line finding that we discovered was that for 2 of these deaths, which we frame in the notion of deaths of despair with regards to these 3 areas, that there were declines in 2 of these, but that for combined, we actually still saw that over 150,000 Americans had died from drugs, alcohol, and suicide. Now, overall, the data is really a mixed picture and there are mixed trends. What we saw is that the 2018 death rate is level with the 2017 death rate. And that's the first time since 1999 that there hasn't been an annual increase in this combined figure. But when you really look and then explore into the various causes of death, deaths due to alcohol increase in every age group except for ages 0 to 17 and across every race and ethnicity. We also saw that deaths by suicide increased slower than previous years. In 2018, for example, it increased by 2% compared to a 4% increase in 2017. Next slide, please. When we look specifically at drug-induced deaths, we see that that has actually overall declined, and that's being driven in large part by reductions in overdoses from prescription opioids, and also to a lesser extent, heroin-related overdose deaths. But again, there are a number of other drug types, specifically synthetic opioids, cocaine, and other psychostimulants such as methamphetamine, where we have seen an increase, although at a slower pace than in previous years. And what we also see is that certain populations, you see an unevenness with regards to those reductions. That in fact, we saw that the rates of death among people of color, older adults, and those living in the West with regards to geographic region, that those deaths continue to increase. Next slide, please. So when we think about really addressing these deaths of despair, we recognize that it's a continuum. And one of the areas of focus in particular for Trust for America's Health is in prevention and recognizing the need for increased investments in prevention across that spectrum of prevention, treatment, and care and recovery. We see that certainly there have been increased investments by federal policymakers to take steps in really response, for example, to the opioid epidemic, which has resulted in a number of programs across federal agencies. but there's much more work that remains. In particular, one of the disturbing trends that we're seeing is the increased rates of suicide among Black youth under the age of 13 years old. That Black youth under that age are actually twice as likely to die by suicide compared to white children. And that Black youth suicide has increased by 73% from 1991 to 2017, which goes against actually what has typically been thought, that actually that Blacks and Black youth had lower rates of suicide. And what we understand is that we really must address the upstream factors that harm vital conditions that are needed for positive and healthy outcomes. We need to address issues such as intergenerational poverty, structural racism, discrimination. We need to address homophobia and transphobia to really understand the root causes of what may be leading to these deaths of despair. We also must expand services in educational settings and educational systems, including training and screening and supports to be able to respond, for example, to issues of childhood trauma and to be able to scale up those types of services. And lastly, we also need to expand crisis intervention services and other support services for all populations. Next slide, please. What the recent data also shows us is that there is a shift in the epidemic, where notably, as I mentioned, we saw early on that it was overdoses from prescription opioids, and now seeing these shifts with regards to psychostimulants, and also continuing to see persistence with regards to alcohol-related deaths and suicides. And so these recent data really suggest that we need to certainly focus on holistic approaches and complementary approaches. The increase, for example, in stimulant use requires that kind of complementary approach to opioid-focused interventions, where we're increasing access to behavioral health therapies. That we need to also really implement evidence-based policies to help lower excessive alcohol use, for example, through increasing alcohol pricing or limiting the hours and density of stores that sell alcohol and enforcing underage drinking laws. And we also need to promote harm reduction strategies like expanding access to overdose prevention medications such as naloxone and expanding medication-assisted treatment. Next slide, please. So when we think about certainly investing in prevention, we recognize that that's complementary as well to the necessity of improving our investments in treatment. Because despite some of the investments that have been made, as Ben alluded to, there still are gaps. There are gaps in care that remain. And this slide shows you, for example, with the Health Resources and Services Administration's recent report, that only about 27% of geographic areas have enough mental health practitioners. And the population of these areas with mental health shortages is actually about 120 million people. So needless to say, we certainly need to expand efforts to ensure care and to ensure equitable access to care. We also need to focus on being able to reduce barriers and obstacles to accessing care, whether that's transportation or childcare or other types of social needs that individuals may have. And lastly, we certainly recognize that we are still in the work of working to address and fight stigma and really improving social attitudes toward mental illness and substance use disorders. Next slide, please. Now, while there are gaps in mental health and substance use care, and they are stark, we also recognize that certain populations are especially hard hit. And here, this is essentially showing you that for African Americans who actually have substance use disorder or mental illness, that they actually have high rates of not receiving treatment. And so ensuring services are accessible, that they're available, and that they're also culturally and linguistically appropriate to meet the needs of diverse communities is truly essential. Next slide, please. So we can ask, how do we build out on these recommendations? But in addition to what we do at Trust for America's Health and our advocacy, we've established a cross-sector coalition called the Wellbeing Working Group, which is comprised of stakeholder organizations from public health, mental health, substance use, community health, and other sectors to promote population strategies, population level strategies to really prevent initial onset of mental disorders and substance use disorders, and do advocacy, for example, on the Hill to advance evidence-based policies. And if you'd like to learn more about this specific group, we'd love for you to contact our staff member, Jonah Cunningham. Next slide. Some examples, and I'll just go quickly through this with regards to some of the actions that can be taken are: one, certainly expanding mental health and substance use disorder services. Two, the importance of having accurate disaggregated data so we know that which communities are being disproportionately impacted, and directing resources equitably into communities that are truly in greatest need. And that we do need to address the social determinants of health and underlying causes and root causes of disparities and inequities and mental illness and substance use more broadly, so that we can address these longstanding structural and systemic inequities. Next slide. Here's our contact information. We have all of these resources available on our website. So if you haven't visited our website, we encourage you to do so. And we also have a bi-weekly digest that you can subscribe to, and follow us on social media. I look forward to engaging in the dialogue at the end of the presentations. Thank you.
Thank you, Nadine. Extremely important information. And there was a few questions that came in. You can go and look at the multiple reports that Nadine mentioned. You could start at paininthenation.org and see some of the information that she lifted up. You can also find the Pain in the Nation reports on both the Wellbeing Trust and the Trust for America's Health website. And from that, we will go to Dr. Jack Westfall. Jack, we're gonna let you talk a little bit about deaths of despair from COVID-19.
Yeah, so I'm gonna sort of follow up on that, the bad news of what's going on right now to potential for worse news unless we do something. We're going to talk a little bit about the deaths of despair related to COVID-19. I think you heard sort of that definition of deaths of despair: suicide and drug overdoses and drug abuse and alcohol, and how those have grown over the last decade. As we were thinking about early on the impact of COVID, even in March, we started realizing that unemployment was going to rise, that there was going to be an extended period of social isolation, and we wondered what that would do to deaths of despair. Next slide, please. So we actually developed some models based on the Great Recession of 2008 and the impact that that had on deaths of despair, specifically suicide and drug and alcohol overdose. We added in a nudge factor related to isolation. There's really good evidence that isolation impacts individual mental health, but there's not a lot of literature on the impact of large-scale isolation on a population. It's been a long time since we've had this sort of social isolation in the world. And the third part is around uncertainty. The literature on the impact of uncertainty is also there for individuals. Uncertainty can lead to despair, can lead to dread and fear, stress and anxiety. But again, there's no literature on what that does at the population level. Next slide. So we created a series of projections based on three different possibilities of suicide mortality. We looked at 1% increase per point increase in unemployment, 1.3% increase, and 1.6% increase. And then we projected that over what kind of recovery there might be to the economic downturn. We know that unemployment soared in the first few months of COVID, anywhere from 10 to 20%, depending on the state. And we're not sure how fast that's going to recover. So we projected a slow, medium, and fast recovery. Applying those numbers, you can then see that for a 1% increase with a medium recovery, there may be an additional 50,000 deaths of despair. But if you have a 1.6% increase in mortality with a slow recovery, it could be 154,000 deaths. So somewhere between sort of 50 to 150, we sort of settled on a number around 75,000 deaths of despair in the next 4 to 10 years based on these data from previous examples. This is essentially based on what we know about the impact of unemployment on deaths of despair, because we know that social isolation has a negative impact, as does uncertainty. We sort of lean towards the higher end of this spectrum. So is it 65,000, which is sort of the middle of the road here, 1.3% increase in mortality with a medium recovery? Is it 75 if you have a little bit of impact on by social isolation? Or is it 100 if you have a slow recovery and higher rates of mortality related to deaths of despair? Next slide. Here you can see that applied at the county level, and this is based on the previous data from the Great Recession and the unemployment rates between 2008 and 2015. The darker is worser and the lighter is better. However, next slide, I'd like to just point out that this Great Plains area in the middle, next, you can, I think, move that forward. There should be a little circle there. Oh no, go back. So the Great Plains area, you know, that's a lot of agriculture. It's self-employed farms and ranches. And while there's a huge economic downturn, it doesn't result in unemployment to the same level as other areas that do industry. And so we're still trying to figure out what is the potential for deaths of despair and the increased deaths of despair in this Great Plains region based on the agricultural downturn as well. Next slide. You know, the take-home messages for this are that this is a prediction based on the past. It's not destiny. The change and trajectory, we can change the trajectory and prevent deaths of despair. The current isolation is unprecedented. We don't know what the current quarantining, stay at home, social isolation is going to have. We don't know that impact. We know it impacts individuals, and we predict that it will impact large populations. And I think from data that we're seeing emerge, it is increasing levels of depression and anxiety, which may lead to higher numbers of deaths of despair. The third is that mental health must be part of any COVID recovery testing and tracing efforts. So there's a new workforce of maybe 100,000 contact tracers, and we really encourage that group to learn a little bit about mental health so that as they're doing contact tracing for infection, they may be able to ascertain, screen, and refer for mental health needs as well. Next slide. Primary care, the Robert Graham Center specifically thinks about primary care. And so when we think of primary care, we really equate that with integrated medical and behavioral health. I've worked 15 years in an integrated behavioral health primary care setting. It means that that place can also work for the entire spectrum of conditions, from hypertension to anxiety to medication-assisted treatment for opioid use disorder, depression, and anxiety. We need to think about how do we be proactive. So not just wait for people to come in, because they're not coming to the practices right now for fear of COVID. They're staying home. So how as primary care can we reach out to those patients unable to come to the office to do screening, ascertain their health and mental health needs? Telehealth, again, is a great tool. There have been relaxed rules and regulations and policies related to telehealth, and we want to make sure that those aren't just during the emergency crisis, that those continue so that mental health services, counseling can be done over telephone, video, through telehealth platforms for the long term. Stigma reduction, as you heard Nadine talk about, is still a crucial component of this. And, you know, I have a question here. How many pickup trucks in your parking lot? I practiced in rural Colorado for a number of years, and we had an integrated primary care center that had dental, behavioral health, as well as primary care. And we used to tease our friends at the mental health center about who parks in their parking lot. And for rural farmers and ranchers, parking your pickup truck in front of a mental health center is part of, well, it's a barrier because of the stigma related to that. And so integrated care offers an opportunity for people to not know what kind of services you're getting at a particular center. And then it's really crucial for us to think about community partnerships. Who else is doing behavioral health in the community? And what are the safe venues for emotional expression in the community that are beyond just the mental health center or even the primary care center? Next slide. I'll just finish with a couple of points. This is not a call to reopen the country. simply pointing out that there is an association between deaths of despair, economic downturn, and unemployment does not mean that we just need to indiscriminately open the country. We need to make sure that we keep people safe from the infection. And we need policies that can address social distancing and social connection so that people can feel connected. And the other point you've heard already, unemployment too often sheds light on racial inequities in America, and we need to really think about communities of color and how this disproportionate impact can be addressed both policy-wise and clinically. I think that is my presentation. And you can go to the next slide. And thank you very much for providing me an opportunity to share this potential bad news as a wake-up call. And I think you heard Ben say, we're trying to grab you by the lapel and say, hey, let's do something. So I see that there's 185 participants, 2 questions, 9 chats. Let's do something to prevent these deaths of despair. Thanks.
Thanks so much, Jack. Appreciate you. Appreciate the work here. Okay, we're going to go to Cynthia and Rachel, and then we're going to start to turn to your questions immediately following that. So our Kaiser Family Foundation friends, I'll turn it to you all.
Okay, should I unmute myself? Hi, I'm Cynthia Cox. I'm with the Kaiser Family Foundation, and I'm joined by Rachel Garfield, also with KFF. The two of us are working with the Wellbeing Trust on a new initiative at Kaiser aimed at mental health. And I'm going to start by walking through some recent survey data on how COVID-19 is affecting people's mental health. And then I'm going to turn it over to Rachel, who's going to talk about what this all means for the pre-existing challenges in accessing mental health care. So you can go to the next slide. As many of you may know, the Kaiser Family Foundation does routine public opinion polling every month for many years. In the last 3 polls, we have asked questions about how COVID-19 has affected people's mental health. And what we found is that already in March, shortly after the social distancing measures had been put in place, there was a sizable share of the population who was experiencing either a major or a minor impact on their mental health due to the pandemic. By April, early April, almost half of adults said that the pandemic had had a negative effect on their mental health. This seems to have gotten a bit better by May, although it's not clear how much of this may come and go. So we'll be tracking this as things continue. It's possible that with social distancing easing up a bit in May and some people regaining employment, that could have had a positive effect on mental health. But of course, as this drags out longer and longer, we'll only have to wait and see kind of how this is all playing out. So you can go to the next slide. And this slide breaks out the first poll, the one we did in March, by gender and race, ethnicity, and whether there's a child present in the house. So first, looking at how this breaks out by gender, you can see that women were much more likely than men to report having had a negative impact on their mental health from the pandemic. Similarly, Black and Hispanic adults in the US were also much more likely to experience particularly a major impact on their mental health from the pandemic than white adults were. And looking at the last section, whether there was a child present in the house, at first it appears that parents and non-parents were affected similarly. However, if you go to the next slide, and we can break this out by gender, it's actually mothers are experiencing much more stress related to the pandemic than fathers are. And so there seems to be some gender inequality here, likely related to who's taking on more of the burden of childcare during the pandemic. So we'll go to the next slide. So this chart shows how the mental health effects from the pandemic break out by income. And unsurprisingly, people who are lower income are more likely to have a much more negative impact on their mental health. We've also asked this question in different ways. For example, looking at people who experienced job loss, and we see a similar pattern that the economic impacts have also led to people experiencing a major negative mental health impact from the pandemic. We'll go to the next slide. And of course, people who were already in worse health before the pandemic or in the early stages of the pandemic were at higher risk of contracting the virus, or rather were at higher risk if they did contract the virus of having an extreme or severe illness. And so that has also shown here that people who were already in fair or poor health before the pandemic were much more likely to experience stress related to the pandemic that had a negative impact on their mental health. We'll go to the next slide. So this is not from a Kaiser survey. This is from a couple of government surveys. And I wanted to try to put some of these numbers in context. So with some caveats, we can look at some survey work that was done by the National Health Interview Survey, where the survey looks from the first half of 2019, so before the pandemic. And it asks similar questions that are shown on the Household Pulse survey, which you see in the orange column to your right, which was asked during the pandemic. And so these questions assess whether people are having symptoms that are consistent with an anxiety disorder and or a depressive disorder. And so you can see, there's different methodologies here. So, take this all with a grain of salt, but it does appear that the share of adults who are experiencing symptoms consistent with an anxiety disorder or a depressive disorder has grown significantly during the pandemic. And so this ties into what Rachel is going to talk about, which is the pre-existing barriers to mental health care and the increased demand for those services. So I'll pass it over to Rachel with the next slide.
Thanks, Cynthia. So I do want to shift gears just a little bit from the focus on mental health to focus a little bit on mental illness and what was happening even before the pandemic. I think appropriately so, there's been a lot of focus on the uptick in need and demand for services, new problems that people are having as a result of everything happening right now. But I think it is important to bear in mind that this increase in poor mental health is happening against a backdrop of a system that already had very high rates of prevalence of mental illness, of substance use disorder, and a system that was already pretty strained to address that need. If you could go to the next slide, please. Even before the pandemic happened, as many people have noted, there were major issues with the behavioral health system in the United States. And what you can see in this slide is looking at data, which is unfortunately the most recent data we have, but is obviously from before the pandemic. There are pretty high rates of unmet need, even among people who have a known mental illness. And I think it's notable that, even over a third of people who have a serious mental illness reported that they went without needed services. Similarly, even among adolescents who have a major depressive disorder, pretty high rates of unmet need for services or people not getting treatment for services. So in the context of thinking about what's happening right now in this surge of poor mental health, there is a large group of people who had likely diagnosed illnesses before, who were not even getting services before. In addition, for the people who were getting services, there are likely challenges with the continuity of care for them. So someone who was in treatment, who was managing their mental illness or their substance use disorder, is likely facing challenges with continuing access to care and being able to get the services they need. So there's a lot of challenges going on right now, both for people who are newly affected as well as those who have been affected for quite some time. Next slide, please. To kind of wrap up and go full circle back to, I think, where Nadine also focused in her presentation, what's happening right now really spotlights both existing and new barriers to accessing mental health care and substance use disorder services. And I think in some ways does provide an opportunity. We can maybe think about this as a window of opportunity when increased attention can perhaps help policymakers shine light on some of the underlying challenges that have been present in the system for quite some time. Here I've laid out a few of them. These are probably very familiar to most people who are on the call right now, but just to make sure we're all on the same page, you know, there are major issues in the financing and organization of care for mental health. Things like limited insurance coverage, even for people who do have insurance coverage, problems with cost, limited networks, and things like that. The provider supply issues that Nadine talked about, as well as ease of using services. So are providers open when people can go see them? Can you get an appointment? And lastly, issues of cultural competency, which Nadine also talked about. So are providers able to speak the same language as people? Are they sensitive to the cultural background that people are coming from? There are also a host of social and individual factors that affect access to care. I don't mean to imply that these are not amenable to policy, because many of them are, but they tend to be a little bit more individually based. So things like non-financial access barriers. Can you get time off of work to go visit care? Do you have transportation to get to an appointment? What is your health literacy? How empowered are you to be able to navigate the system? And then lastly, in that category, I did list stigma, which many people have also brought up. And then all of this is overlaid over, you know, not just what's happening with COVID-19, but also other big policy shifts that have been going on over time. So I think in some ways we are still dealing with the repercussions of the Great Recession, even though it was, you know, over a decade ago now. Some of those lingering effects I think are still being felt, particularly when you look at what's happening with the opioid crisis, which according to some indicators, we were beginning to claw our way out of a little bit, but I think as Nadine also noted, there were some concerning indicators there as well. So next slide, please. So to wrap up, I just wanted to highlight an initiative that KFF is doing with Wellbeing Trust in collaboration to try to sort of nudge us towards some policy action to address these challenges. And there are a host of things being done under this collaboration. One I wanted to highlight in particular is a series of state fact sheets that we are planning to release within a few weeks that will pull together data on various aspects of mental health and substance use, particular to a state, and also compare that to the nation. And this is meant to provide data to underpin those policy actions, many of which I think will happen at the state or perhaps more local level. We've also recently launched interactive data where people can go and pull data on their state, not everything that's in the fact sheet, but a lot of what's in there, compare it across states. And then we are also developing a series of policy briefs, again, to try to provide data and analysis to underpin policy action in that area. So I'm going to wrap up there, and I think that leads us into Q&A.
Thanks, everybody. What a wonderful overview and description of some of the data that are available out there. I want to thank you all for your time today giving us those presentations. We want to turn to some of our questions, and I know that some of these have already been answered in the chat box, but I want to go ahead and lift up a few of these just to begin with. So one of the first questions, which I think is really critical for us, especially those of us that are tracking our own kids or maybe friends of our family, those kids, is what data and impacts are we seeing on children and teens' mental health from COVID? And I don't want to pick on our resident pediatrician or family doc, but I do think that there's a lot of conversation happening nationally here. So does anyone want to speak to what type of data or trends that we're seeing with children and teens for mental health?
So this is Jack, and I'll jump in here, and I don't have the answer using current data. I don't know what's going on currently. I'm looking forward to actually seeing some current data. I do know that there's a group that we're part of that's working about how do we think about kids going back to school or not going back to school? How do we keep people safe at home in homeschooling situations? So I think there's a whole host of issues related to this group. I will say that, back during World War II, there was a study that showed children who were moved to the country for their own safety, in London, out of London into the country, away from their homes and away from their families, in the attempt to keep them safe from the bombings, actually over a 10 to 15 year period did worse from a mental health standpoint than the children who were kept in London who experienced the bombings. So I think the actual experience of this may not be as big a factor as how it is framed for them in their home situation. Is this seen as a desperate, hopeless situation, or as a joint effort for us to overcome? And there's another question that says, while seeing an increase in stress and anxiety, they've seen a decrease in suicide. And I think part of that is that we have been given as a country a universal purpose to survive COVID. And so acutely, that purpose may keep people who would have been suicidal or susceptible to drug and alcohol abuse from moving forward with those decisions. It's unclear if that impact will persist as this continues. And so I think that initial purpose may wear off of, well, I survived COVID and now I don't have a job. And so I think we have to be thinking about sort of 3 to 6 months after this moves on and see where the recovery is from that standpoint.
And Ben, if I could add to what Jack said and really excellent points that he made, I think that setting data aside, I think what we also know is certainly the impacts of this for children and adolescents, and thinking about this through developmental stages as well. For adolescents who really at a time like this, how social connections and peer support are so important to their development. And so thinking about the impact of school closures on that social connectedness, that there can be feelings of sadness, even if a feeling of grief of something has been lost, and whether it's milestones of things like graduations and even proms or sporting events that youth have, to just the day-to-day social interactions. We recognize the importance of the school setting for that, or even younger children who can't have play dates and interact with their peers in that way. And so I think we recognize that one, it's as Jack said, how do you actually help children through that process, being able to vocalize that and validate the feelings that they're having, and then trying to provide new routines, new patterns for them to be able to work through those types of stressors, and understanding too that youth also can perceive the stress and anxiety and the experiences that their parents and caregivers are also experiencing, and so that it really has a familial impact as well.
Thank you. Rachel, Cynthia, anything you all want to add on that one?
Unfortunately, our surveys are only of adults, so we don't really have much more to add there.
Okay, that's fine. Thank you. I'll just add quickly that there have been a couple of articles published recently in The Lancet that have addressed the issues around social deprivation in children and the impact that can have on their overall mental health and well-being. And then interestingly enough, those of you that will look at other countries and how they're faring with the pandemic that have been going at this a little bit longer, like China, for an example, there are some studies coming out looking at especially the negative impact on a child when they've had to quarantine themselves, like if the child is sick or the parents are sick. So really hard topics and things that we need to pay attention to as a country. So thanks for the question. All right, I'm gonna go to a couple more questions here. So this one is very specific, but it's a really important question too, which is what are we hearing regarding CMS's willingness to extend the broadening of the telehealth rules? And for those not as familiar with others around what's happened with telehealth and some of the opportunities within the emergency order, it's really loosened some of the privacy restrictions, meaning that some of the platforms that were historically not allowed to be used for interventions, medical or mental health or otherwise, through our phones are now allowed. And some flexibility, not only how we finance those, but also the tools that we use. So I'm curious if any of our panelists want to speak to that, if they're hearing anything on the Hill or in their respective communities on CMS's willingness to broaden these rules.
So I'm going to answer in a somewhat frustrating way, but not talking about stuff specifically what CMS is doing, but we have been tracking what states have been doing within their Medicaid programs under the guidance that, or the flexibility that CMS has to date allowed. And it is true that the vast majority of states, I think our last count was 41 of them, have taken up some aspect of this new flexibility to either loosen rules about having established relationships, loosen other types of rules that were in place before the pandemic, to help people access all sorts of services, but specifically behavioral health services within the Medicaid program. So states are making a lot of action in here. I think one thing that we're trying to track and keep a close eye on is how long will these continue for? One thing that I was trying to focus on, or we've been trying to remind people, is a lot of these barriers have been in place even before. And so once we declare ourselves out of this public health emergency, that need for services is not going to go away. And so there's going to have to remain some sort of expanded capacity for care through new modes as well. So we've been trying to track it in real time as much as possible, and keep a close eye on it.
Ben, I would say, from the Hill and the congressional perspective, there is debate ongoing now with regards to, whether this can become permanent. There's some encouraging signs in that the chair of the Senate Health Committee, the Health, Education, Labor, and Pension Committee, Senator Lamar Alexander, has spoken out in favor of the permanent rule changes, but ongoing discussions in Congress.
Thank you. Okay, this is a very specific question, but it's actually, I think, a really useful one. So I don't want to have to go back too far into our slides, but Rachel, there was a question specific to you on one of your figures in the slide. And so, Alicia, if we could pull up figure 8, which I think was the maybe third to last slide that Rachel had, there was a question about, can you please explain the sample and population on figure 8 and who is captured by that slide? And so, Rachel, I don't know if you want to kind of take that one.
Sure, I'd be happy to. So this is some survey data that's collected by SAMHSA through the National Survey of Drug Use and Health. It's an annual survey that aims to look at a range of issues in behavioral health. The folks who are shown, the rates that are shown on this slide are among people who the survey identifies as having a mental illness. And for adults, they're stratified by the severity of their illness. And then within that group, showing the rates who said they did not receive any services in the past year. So adults is anyone age 18 and up, and adolescents are aged 12 to 17. And again, this is just people who the survey identifies as having, for adults, either any mental illness, or for children, major depressive episode. When we share the slides with the participants, which I think is the goal, there are some pretty detailed notes underneath this slide that also lay out exactly how those things were measured, and I'd be happy to provide more detail about that.
Thanks so much, Rachel. So let's go back quickly to telehealth, because that seems to be one that has caught folks' attention here. And talk a little bit more about this. I know many of you have strong opinions here, but let me ask the question first. The question is telehealth able to fill the workforce capacity challenges that have been described? Are there other digital connected health tools that are helping fill the gaps in capacity? And it's a great question. It's quite nuanced, because I think many of us have strong opinions about this, but I'm wondering what you all think about that. How will telehealth help augment, or in some cases replace or enhance, the capacity of our workforce? And what other tools might be available out there for folks to leverage at this time?
Well, I guess just to give kind of a general answer of what we're already seeing right now is that just healthcare utilization in general has dropped significantly during the pandemic, especially at outpatient clinics and physicians' offices. And there's been some research by IQVIA, which is a group that has access to current claims data, that has shown that although telemedicine use has increased by, I think, like 300%, it still isn't nearly enough to compensate for the drop in in-person visits. So it would have to increase much, much more than what we've already seen to be able to compensate for even just what normal demand is.
So this is Jack, and I'll just weigh in that I think telehealth's here for, we've been trying to think about how to do telehealth for decades, and I think it's here to stay. The stuff that Dr. Gracia talked about, the Hill is talking about this. There are people who are supportive of this. I think it's going to be the next decade of research identifying what happens best by telehealth, what needs in-person care. And so I think we owe it to our country and our patients to do some real robust research on how do we do this the best way. We also have to think about who has access to this. So again, from a rural community, where is the bandwidth that can do a video conference? Many of my patients don't have the capacity, either technologically or from an internet and bandwidth, to do that. There are patients who have limited data plans that don't provide access to full video streaming so that you could do a interaction. And so I think we have to study that. I think it's here to stay. It will always be part of it. I think one of the places we really need to be careful is thinking about how do we use telehealth to support usual source of care rather than telehealth out of a box that's just anybody. And there are lots of companies emerging who are providing inexpensive telehealth platforms that may not fit the bill for usual source of care, for comprehensive primary care that includes behavioral health, and for long-term relationship-based care. And so I think we really have to be careful about what kind of telehealth we think about and how we deliver that.
And I just to Jack's point, underscore the issue that he raised, which is the accessibility, because telehealth absolutely can, be a great resource and tool, especially now as we're seeing within the context of the pandemic. And I'll add also even thinking about the issue of stigma and being able to have services that you don't actually have to go to a specific provider, but you can actually utilize those services. That might also be a strategy and a tool in addressing stigma and accessing services, where we need to have the broader goal, certainly, of just ending stigma with regards to seeking those services in the first place. But I will also say we do have to be very intentional to ensure that it doesn't exacerbate disparities and inequities. Jack referred to specifically rural communities and access, for example, to broadband to be able to engage in telehealth. We can say that as well in many communities of color, in urban communities that also similarly lack access to broadband, to be able to utilize those services, and also to ensure. Similarly, when we talk about the importance of culturally and linguistically appropriate services, that applies as well to telehealth as it does to in-person services. And so ensuring that those modalities are accessible, that they're equitable, and that they're really reaching the communities that are in need, because we already see that there are shortages with regards to certain areas. And so then overlaying that with telehealth, where there might be digital disparities, could then potentially exacerbate it. So I think it's both a tool as well as something to be very cognizant of, as ensuring that it doesn't exacerbate an inequity.
Just based on the number of questions that are coming in on telehealth, I feel like I'm going to head and put a plug in this. We need to do a telehealth specific webinar for the future. So thanks for these great questions. I'm going to shift ever so slightly back to the data and some of the numbers. And as was described throughout all the presentations, there are profound disparities. And one of the questions that came through that I think is worthy of discussion here, and then we're going to wrap up after this, is that the question says this: we are seeing large disparities in the impacts of COVID-19 within communities, higher rates in communities of color. What ways can we best support communities of color with mental health services during and after the pandemic?
I'm happy to start. I think one, it's really understanding and meeting the communities where they are, in recognizing that the communities are not monolithic, and that there can be, for example, really longstanding structural barriers, but also systemic barriers to accessing services. And so how best can various communities be able to access services and services that they feel are really meeting and addressing their needs. That's working with trusted partners in communities. That could be working with faith communities, working with community health workers, and promotoras de salud that work specifically in Latino communities. It's really being able to actually adapt and provide services that most reflect the ways in which people are comfortable in accessing information, as well as being able to utilize those services. And so it's not a one-size-fits-all approach. It's really ensuring that you're addressing what are some of the most significant needs that a community has. I think that the diversity of the workforce that is reaching out to various communities, and in addition to the cultural competency of the workforce, is also important. A lot of this is when we talk about, certainly at Trust for America's Health, how you respond in public health emergencies. Those relationships and networks, the time to develop those are prior to the emergency. And so you really look to what are the assets that exist already in communities. And it may even be utilizing messages, for example, about the importance of talking about mental health and utilizing, for example, radio stations and other modalities to try to normalize the fact that we're all feeling a level of stress and anxiety, and it's okay to seek help, to really expand on your social connections and to seek mental health services if you need it.
So I just want to jump in there and add that this may be an unprecedented opportunity for us to destigmatize mental health issues, because everyone in the world, and certainly in the United States, is facing some stress, anxiety, of social isolation, of physical distancing, of uncertainty. People are stressed. And even I'm surprised it's only 35% of people say they were stressed in the last 2 weeks. My partners, it's everyone that comes into the practice or makes a call. So I think we have an opportunity to utilize this epidemic of stress, anxiety, and mental illness to think about this is part of human response. Like when you get pharyngitis and have a sore throat, when you get a cold and have a cough, when you are stressed and get anxious, there are things that happen, and we can potentially use this opportunity. And a famous, mayor said, "Don't waste a crisis." And I think we should not waste this crisis to be able to think about how do we leverage this to add on additional destigmatization around mental health.
Can I just add one thing to those really excellent comments about sort of how to deliver services to people who need them as well? I think it's also important to bear in mind that there is a broader policy context that is disadvantaging certain populations. So there are very simple things like extending insurance coverage to make sure that state decisions about whether to expand Medicaid don't disproportionately affect groups of color, which we know they are right now because of where people tend to live. So also bearing in mind that we need to get people into services, but there are some very sort of broader things that can be done to make sure that there's a broader support network for people once they are in that system.
Okay, well, we have more questions and we've got 1 minute. So we're going to do really fast, rapid response here. Would each of you recommend one thing that we could all do right now to do a better job getting in front of these deaths of despair and addressing some of the mental health crisis in our nation? One thing we could do right now, one sentence, one word, you name it, go.
I think there's a role for private insurers here too, and some we haven't really talked about that much, but some private insurers have been voluntarily trying to get out front with mental health, but not all of them are, and so that would be something that could be done.
Thank you.
I would strongly recommend everyone on this call handwrite 5 letters to your family, friends, neighbors, colleagues, and include in that letter a card with an envelope so that they can do the same thing. Part of social connection is the personal connection, and having written 1,000 cards in the last 3 or 4 years, it is a way to connect with people across space and across time. It spends 3 days in the mail, so it doesn't have any COVID on it by the time it gets to them. I would strongly encourage everyone here, reach out and connect with 5 people that you've not connected with in the last 2 weeks.
Thanks, sir.
I echo both of those, and seeing the need. I think something we can also do is expanding the crisis intervention services. We have seen, for example, that the disaster distress helpline has seen an increase by almost 900% of calls compared to last year. There's a desperate need for this, and trying to make it even more accessible if we move to a 3-digit number or provide additional resources and services to really try to help the nation that's really in need and in pain.
I'll go super fast, Ben, and I'll end where you started, which is I think we need a major investment as a country in this to support expanded services, expanded insurance coverage, et cetera. And that's, there's no such thing as free care. So there is going to have to be some investment of resources and some shift towards behavioral health services.
Thank you. Thank you, Jack, Nadine, Rachel, and Cynthia. You guys are amazing. I appreciate your time today. And thank you for watching us and joining us on this, this webinar, this Healing the Nation webinar. Just as a reminder, this has been recorded. It will be posted on the Wellbeing Trust website. You will also get a link to the recording as well as a link to the PowerPoints through the email that will come out from Krithika. So thank you. I look forward to joining us next month. We appreciate your time today, and everybody be well.